Patent Ductus Arteriosus. Dr. K. van der Dunk. Cardiothoracic Surgery. Charlotte Max Johannesburg Academic Hospital and University of the Witwatersrand. Hans Meyer Registrar Symposium 3 5 June 2011. Classification of congenital cardiac lesions. Anomalies. Characteristics. A cyanotic. LR shunt equals PBF. Triad. FFT. Chest infections. CCF. PDA. ASD. VSD. AV canal. 2. Obstructive. Often asymptomatic. Coarctation. Aortic stenosis. Pulmonary stenosis. Cyanotic. 3. Decreased PBF. Cyanosis. Childwell. Asymptomatic. Tetralogy. Pulmonary atresia. Tricuspid atresia A, B. TGV plus PS. 4. Increased PBF. FTT. Truncus. TAPVC. Tricuspid atresia C. TGV. Failure to thrive. FFT. Congestive cardiac failure, CCF. Pulmonary blood flow, PBF. Pathophysiology of LR shuns. Clinical importance of pulmonary vascular resistance. Neonatal pulmonary artery pressure, PAP, greater than that of adults. Reaches adult levels by 2 to 3 months of age. If PAP remains elevated in presence of a shunt, development of pulmonary vascular obstructive disease, PVOD. Patent ductus arteriosus definition. Also called ductus of Budali. Normal vascular structure in fetal life. Extracardiac lesion. Directly connects pulmonary and systemic arterial systems. Persistence of ductus after 3 months and postnatal period abnormal. Patent ductus arteriosus definition. 4 distinct clinical forms. Isolated PDA in otherwise healthy child. Isolated PDA in premature baby. Associated with more significant cardiac defects. As a life-sustaining structure in cyanotic or left-sided obstructive lesions, ductal dependent. Patent ductus arteriosus, historical background. Ductus arteriosus and its postnatal closure described by Galen in 131 AD. Physiologic importance of ductus arteriosus elucidated by Harvey in 1628. 1938 Robert Gross at Boston Children's Hospital equals first successful ligation. 1967 Portsman used polyvinyl alcohol plug placed with catheter to close PDA. Indomethacin introduced by Heyman in 1976. 1991 Laborde performed first vas closure PDA. Patent ductus arteriosus embryology. Derived from distal aspect of the embryological left sixth arch. By 6th week of gestation, ductus arteriosus carries between 55 and 60% of the combined ventricular output. Patent ductus arteriosus embryology. Diverts blood away from higher resistance pulmonary circulation to descending aorta and low pressure umbilical placental circulation where gas exchange occurs. Ductal flow directly from PA into descending aorta. Ductus equal in width to descending aorta and appears as direct extension of PA into descending aorta. Patent ductus arteriosus fetal physiology. Maintenance of fetal ductal patency. High levels of circulating and locally produced prostaglandins, PG2 and PG1. As fetus matures, ductal smooth muscle becomes more sensitive to vasoconstricting effect of PO2, but low PO2 maintains duct patency. pH plus other factors play a role. RV and LV function in parallel plus share systemic and placental circulations. Patent ductus arteriosus histology. The wall of the ductus differs from the surrounding vascular structures. Media deficient in elastic fibers. Composed primarily of poorly organized smooth muscle cells in a spiral configuration. Intima thick with increased number of mucoid-filled structures. Smooth muscle sensitive to environmental factors, vasodilating effect of prostaglandins and vasoconstricting effect of PO2. Patent ductus arteriosus postnatal events. At birth, rapid circulatory changes. RV and LV function in series. Lung ventilation PVR drops and pulmonary blood flow increases. Due to increased pulmonary venous return, LA pressure rises and PFO closes. PDA closes. Initially functional and reversible. Later anatomical and irreversible equals ligamentum. Patent ductus arteriosus postnatal ductal closure. Postnatal closure occurs in two stages. Functional or reversible closure, contraction of medial smooth muscle occurs within 10 to 15 hours after birth in full-term neonates. Anatomic or irreversible closure, connective tissue formation with fibrosis produces ligamentum arteriosus completed by 2 to 3 weeks. Patent ductus arteriosus mechanisms of ductal closure. Contraction of smooth muscle cells due to increased PO2 following lung ventilation. Decreased PG levels. Removal placenta equals source of circulating PG. Blood flow to lungs removed PG from circulation. Contraction of smooth muscle greatest at pulmonary end, extends to aortic end. Closure may be incomplete at aortic end, ductal ampulla or ductal bump. Patent ductus arteriosus premature babies. In preterm babies, overall incidence 30%. Histologically normal ductus but immature. Less sensitive to vasoconstricting effects of PO2. More sensitive to vasodilating effects of PG. Less likely to respond to postnatal conditions of closure. Trial of Indocid. Early surgery if Indocid fails. Patent ductus arteriosus term infants. In term infants. Histology different from normal ductus. Media contains elastic lamina similar to aortic wall. Smooth muscle organized in fine helicoid spiral fashion. Intima thick with a complete internal elastic lamina. Variable mucoid deposits, lie mostly in media. Is considered a congenital malformation. Patent ductus arteriosus anatomy. PDA equals extension of MPA. Curves under the aortic arch. Joins descending aorta at acute angle of fume beyond origin of LSCA. Recurrent laryngeal nerve curves around PDA. Anatomic variations. Patent ductus arteriosus diagnosis. History. Physical examination. CXR, heart. Lungs. ECG. Echocardiography, ECHO, plus color Doppler. Often diagnostic of the anatomy. Many operations done on echo data only. Chest X-ray, CXR, electrocardiogram, ECG, echocardiography, ECHO. Patent ductus arteriosus diagnosis. Cardiac catheterization and angiography. To assess PAP plus PVR and response to oxygen and pulmonary vasculature. To assess operability. PVR greater than 8 Wood units in 100% O2 constitutes a contraindication to surgery, X80 to convert to Dyne's second/SM5. Interventional cardiology. MRI. Patent ductus arteriosus echocardiography. Patent ductus arteriosus angiography. Patent ductus arteriosus pathophysiology. Dependent on two factors. Size of shunt. Difference between SVR and PVR. At birth, PVR elevated little flow regardless of size. As PVR drops, LTRT shunt increases dependent of size of PDA. Persistent fetal circulation. Patent ductus arteriosus physiological classification. Physiological classification depends on the size of the PDA, on the degree of pulmonary hypertension and the pulmonary vascular resistance. Important in terms of surgical indication. Classified as small, moderate or large. Patent ductus arteriosus physiological classification. Small PDA. QPQs less than 1.5 to 1. Normal PA pressure, normal PVR. Asymptomatic in childhood. Lifelong risk of infective endocarditis. SB on PDA minus PV minus AOV minus mycotic aneurysm of descending aorta. Surgery on infected PDA risky. Interventional cardiology, transcatheter closure. Patent ductus arteriosus physiological classification. Moderate size PDA. Moderate pulmonary hypertension. Do not develop Eisenmenger syndrome. Mild symptoms, some growth retardation, fatigue on effort. May be asymptomatic. Presence of loud murmur with diastolic spillover plus thrill. Patent ductus arteriosus physiological classification. Large PDA. Direct large communication between MPA and aorta. PA pressure equal to systemic. QPQs increased to a degree dependent on PVR. Can develop Eisenmenger syndrome. CCF, FTT, chest infections. Systolic murmur. Patent ductus arteriosus physiological classification. Eisenmenger syndrome. Severe pulmonary vascular obstructive disease which is irreversible. Presence of suprasystemic PA pressures and PVR with shunt reversal, right-left shunt. Increasing cyanosis. Death. Patent ductus arteriosus incidence. 5 to 10% of all congenital cardiac defects. MF ratio equals 1, 2. 1 in 1/600 term-alive births. Incidence higher in preterm babies equals 20 to 30%. Spontaneous closure. Common in premature babies. Rare in term infants. Patent ductus arteriosus incidence. Duct not closing postnatal equals pathological. From partial closure to wide open. Factors. Hypoxia. High altitude. Respiratory distress syndrome. Maternal rubella in first trimester. Low gestational age. Associated cardiac malformations. Patent ductus arteriosus complications. Death in infancy high due to CCF for large PDA. Death in early, middle adulthood. CCF in moderate size PDA. PV odd plus Eisenmenger in large PDA. SB equals complication of small PDA. Respiratory tract infections. Patent ductus arteriosus complications. Ductal aneurysms. Dilatation of the PDA or remaining ductal tissue. Spontaneous or postoperative. Spontaneous equals true aneurysms. Postoperative after PDA ligation. Often false aneurysm. Can be true aneurysm. Patent ductus arteriosus complications. Ductal aneurysms. Spontaneous infantile ductal aneurysm. Present at birth or shortly thereafter. Often regress spontaneously. Second type develops in childhood or adulthood. Due to patency at aortic end. Greater tendency for progressive dilatation and rupture. Patent ductus arteriosus treatment. Medical therapy. Depending on symptoms. Anti-failure treatment. Inotropes. Ventilation. Antibiotics. Pharmacological treatment, Indocid. Surgery or intervention. Presence of a duct is an indication for closure, except if pulmonary vascular obstructive disease. Patent Ductus arteriosus treatment. Premature babies. Presence of large PDA associated with organ hypoperfusion plus do not tolerate LV overload well. Trial of indomethacin equals inhibitor of prostaglandin synthetase. 0.1 to 0.2 mg, kg 12 to 24 hourly x3 doses. Associated with hepatic, renal, platelet dysfunction. Inefficient in term babies. Patent Ductus arteriosus surgical technique. General anesthetic plus ventilation. Invasive monitoring. Risk of hypothermia. Patient on right side. Left posterolateral thoracotomy and fourth intercostal space. Latissimus dorsi incision. Patent Ductus arteriosus surgical technique. Mediastinal pleura opened along descending aorta, to origin of LSCA. Superior intercostal vein. Care taken to avoid vagus nerve. Recurrent laryngeal nerve defines PDA, but don't go looking for it. Patent Ductus arteriosus surgical technique. PDA dissected with blunt-angled instrument until completely free. Patent Ductus arteriosus surgical technique. Dissect under aorta on both sides PDA. Patent Ductus arteriosus surgical technique. Subtraction technique. When large PDA plus PHT. Patent Ductus arteriosus surgical technique. PDA ligation. Patent Ductus arteriosus surgical technique. PDA division. Patent Ductus arteriosus surgical technique. Mediastinal pleura is closed. If bleeding, closure will tamponade bleeding and allow expiration. One single pleural drain for 24 hours. In small infants, intercostal muscles approximated with a continuous suture. In older children, 1 or 2 pericostal sutures placed. Patient usually extubated post-op. Patent Ductus arteriosus surgical technique. In premature baby. Sick, communication with anaesthetist essential. Handbagging. Need to release the lung to allow ventilation. Proper dissection essential. Clip. Single ligation. Patent Ductus arteriosus surgical technique. PDA with severe reversible PHT. PDA with single pulmonary artery. Need cardiac cath and evaluation PVR. Presence PFO. Partial ligation PDA. Restudy later plus interventional closure PDA. Patent Ductus arteriosus surgical technique. Surgery in adult ductus. More difficult, surgical risk higher than in children. Duct may be calcified. Consider median sternotomy and CPB. Patent Ductus arteriosus postoperative complications. Accidental ligation LPA or aorta in small babies, importance of proper dissection. Recanalization of ductus, rare even with ligation if properly done. Left vocal cord paralysis, phrenic nerve paralysis uncommon. Kilothorax, rare. Bleeding. Aneurysm of PDA. Patent Ductus arteriosus postoperative complications. Patent Ductus arteriosus other therapeutic modalities. Interventional cardiology. VATS. Patent Ductus arteriosus transcatheter closure. Patent Ductus arteriosus transcatheter closure.